Good afternoon, everyone. I am so excited to be back at the Roundtable annual meeting to share findings from our recent publication on colorectal cancer facts and figures. And I'm especially thrilled to be partnered with the next session, which is a topic that's very close to my heart, and it's the extraordinary burden of colorectal cancer in the Native American community. So I'm going to try to help set the stage for that so that better why it's so important to increase screening in that population. So let's go ahead and get started. So as everyone I think in this room is aware, colorectal cancer remains the second leading cause of cancer death in the U.S., despite many opportunities for preventing the disease and detecting it early through screening. And for that reason, the American Cancer Society publishes a deep dive in colorectal cancer statistics in the U.S. every 3 years in two formats: a facts and figures report for a lay audience and a scientific article published in the CA journal. And these were just published this past March. Some of you have heard some of this before if you attended the Roundtable's March webinar, but I've tried to freshen it up a little bit. So the objectives in these publications and the topic of my presentation today is to monitor progress against colorectal cancer, look at how far we've come and where we have yet to go. Also reporting on notable and emerging trends, which we have a lot of right now. A lot of changes happening in colorectal cancer in the overall data. And then also looking at the disparities, which are always persistent with big gaps by state and racial and ethnic group. And then, as I mentioned, I'm going to spend some extra time today looking at the burden in the Native American community. I'll go through this quickly. If you have any questions, you can ask me later about the methods, and they're detailed in the paper. But basically, we achieve our objectives by analyzing high-quality population-based cancer incidence data from the SEER program at NCI, the National Program of Cancer Registries at CDC, and a combined data set of both of those sources in a customized format that we receive from the North American Association of Central Cancer Registries, which is a very important organization. It's an umbrella organization that ensures high-quality cancer reporting in the U.S. And a unique feature of this data this time is the availability of delay-adjusted incidence rates, which are really important for trend analysis because there's a delay in case capture. It takes time to collect these cases and make sure everything's right. And so NCI developed a method that we can adjust the current rates so that they will anticipate what we're going to see. And so we have these at a national level since 1998 from NACER. So a lot of the trends I'm going to show you will be from 1998, and these offer 90% population coverage. So they really do show what's happening in the US at the population level. Our mortality statistics are based on the underlying cause of death that's reported in death certificates and collected by the National Center for Health Statistics, although today I'm mostly going to be focusing on incidence. And then also, because reported cancer incidence and mortality data lag 2 to 4 years behind the current year because of the time it takes to compile and disseminate the data, ACS estimates or projects the contemporary burden in terms of cases and deaths through complex modeling that we develop with statisticians at NCI. And then these are some other NCI software products that we use in our analyses. So you've already seen this figure from Steve earlier, but we have made substantial progress in reducing colorectal cancer incidence rates. The patterns are strikingly similar by sex, despite 30 to 40% higher rates in men than in women. And overall, we've had a 46% drop in colorectal cancer incidence rates since the mid-'80s because of changing patterns and risk factors like declines in smoking, increased use of anti-inflammatory drugs, as well as, of course, the uptake of screening in the past 2 decades. So declines in incidence, as well as increased early detection through screening and improvements in treatment, have also reduced overall mortality by 57% since 1970. Although in the 70s, the declines were solely driven by women because death rates in women began declining several decades before men, and it's notable, if you like history, that women actually had higher death rates than men in the 1930s because of higher incidence rates. The steepest declines are in the wake of the uptake of screening, which happened very rapidly during the 2000s. There were declines in both incidence and mortality of 3% per year during that time period, but those have both slowed now. And screening also has a large impact on age-specific rates, which are shown here. Incidence rates increase for every 5-year age group by 80 to 100%, from age 15 to 49, and then by 20 to 30% after age 55. But interestingly, from 50 to 54 to 55 to 59, there's only a 9% increase. And this is because the natural progression of age-related risk is interrupted by the uptake of screening in people in their early 50s, even though screening rates are only 50% in that age group, but it does make a big difference on the rate. So the high rate in people in their early 50s is actually an example of the success of screening, because a lot of these are cancers that are detected asymptomatically and have a better chance for successful treatment. It'll be really interesting to see how this pattern changes as we get more people screening beginning at age 45. The American Cancer Society began recommending screening beginning at age 45 in 2018. And as has been mentioned, there was a lot of pushback on that at that time. There are some people who still disagree with it. But in the 5 years since that recommendation, there's actually been quite a bit of empirical evidence in support of the earlier age to screening. I think this is one of the most compelling. This is by Ladebohm and colleagues that showed that not only has screening beginning at 45 had a modest impact on colonoscopy volume, which you can see in the figure on the left, but more importantly, among people who are screening for the first time, the prevalence of advanced lesions is the same in people 45 to 49 as in people 50 to 54. So I think pretty compelling evidence to support that earlier age to screen. Although the risk of developing colorectal cancer before age 50 is low relative to older age groups, which has been mentioned, nevertheless, we're estimating 20,000 new cases in 2023 in people under 50, which is the equivalent of more than 50 cases each day in people in their 40s or younger. Of the 153,000 cases expected in 2023, 45% will be in people under 65 years of age, and this is up from 27% in 1995. It's a big change, and it's because of steep declines in incidence in people 65 and older and the success of screening, but it's also because of increasing incidence in people younger than 65. So this slide shows incidence trends. These are probably familiar to you. I've been publishing these for a while, but showing the increase in incidence rates in people younger than 50 on the far left. Since the mid-90s, rates have been increasing by 1 to 2% per year, despite continued steep declines in people 65 and older. What's really interesting from an epidemiologic perspective is what's happening in people in the middle age group, 50 to 64. So if you focus on the trend from 1998 until around 2010, it looks exactly the same as the pattern in the 65 and older age group during that time. But if we look after 2010, what's happening more recently is more closely resembling what's happening in people under 50. And the reason this is happening is because people born after the 1950s have elevated risk of colorectal cancer. And they carry it, the risk is higher with successive generations, and they carry that risk with them as they age. It doesn't leave them when they turn 50. And so someone like me, who was born in 1964, I have higher risk. And I have, for better or worse, aged into the middle age group now. And so people in my cohort and older are changing the pattern that we're seeing in the middle age. And this is called a birth cohort effect. And it's affecting colorectal cancer overall in ways that I'm going to show you in just a minute. So one of these is a younger age at diagnosis that's happening quite rapidly. The proportion of people in their early 50s or younger who are diagnosed has increased from 1 in 10 in 1995 to 1 in 5 today. And the reason this is showing people under 55 instead of under 50, which is the age groups that we've been looking at in the previous slide, is because people in their early 50s actually have the same increase in incidence and mortality as people under 50. And so when we're looking at the change in the age distribution, we want to include that age group. We use the cutoff at 50 because of the historical influence of screening. And the other shift that we're seeing is toward more advanced stage diagnosis. So this slide again shows incidence trends by stage at diagnosis, incidence rates in people younger than 65, so both of the age groups on the left, have increasing incidence rates for both regional and distant stage disease. And even in people 65 and older, steep declines in regional and distant stage have stabilized in recent years. And so as a result, although when we had that big uptake in screening in the 2000s and earlier stage diagnosis, that trend is reversing now. And the percentage of people diagnosed at an advanced stage has increased from 52% in the mid-2000s to 60%, or 3 in 5 diagnoses. So today, the most commonly diagnosed colorectal cancer is stage 3, which is pretty surprising given that in 2019, when that data point is from, 57% of people 45 and older were reporting being current for screening. And so what this shows is that the low rates of screening in the younger people, 45 to 49 and 50 to 54, are contributing to this trend, and it's an area that the roundtable is really focused in increasing those rates. So very important right now. And the last shift I'm going to show you that's happening is in where cancer is developing in the colon and rectum. If you've been around for a while, you'll remember that the big news back several decades ago was a shift toward more right-sided tumors. And these are shown in purple in the diagram there. And this was in large part because the main screening tool at that time was sigmoidoscopy, and it had a limited reach to the distal colon. And so there were more right-sided tumors. But now we have that trend also reversing. This plot shows, this is a long-term plot so that I could show both trends, and this is incidence rate ratios for colon versus rectal cancer. And you can see how that trend has reversed in both men and women. And the reason this is happening is, again, because of this birth cohort effect and trends that you can see in trends by age. Rates of distal colon and rectal tumors are increasing in people under 65 by 1 to 2% per year. And even in people 65 and older, rates of rectal cancer used to be 30% lower than rates of distal colon cancer, and now they're higher. So we're seeing this shift in people older than 65 as well. So as a result, overall, 31% of all colorectal cancers are now in the rectum. And this is up from 27% in 1995. And it's surprising because the rectum only represents 10% of the total large bowel, but also, again, because we've had an increase in screening rates, and screening is most effective at preventing cancers in the rectum. So another opportunity. Now I'm going to shift from talking about trends to talking about disparities in colorectal cancer. We all here know about the large state differences, both in screening and in the burden. Rates range from a low of 27 per 100,000 in Utah to 47 per 100,000 in Mississippi. It's a 75% difference. Rates are also high in other Mid-South states like Arkansas and Louisiana, as well as in Appalachia and Alaska. And the differences by racial and ethnic group are very similar to the state differences. This slide shows incidence rates for those broadly defined OMB groups. And you can see that Native American individuals have the highest rates, 70% higher than Asian American and Pacific Islanders, and 40% higher than white people. And this disparity has doubled in just the past decade from 20%. So again, the disparity between white people and Native Americans has doubled in the past decade. And this is in contrast to a narrowing disparity between blacks and whites. But if we pull out the Native Alaskan individuals from that overall Native American group, you can see the extraordinary burden in Native Alaskans specifically. Native Alaskan people have the highest colorectal cancer rates in the world. And they are, the other thing that distinguishes them is that they're the only group that is not seeing progress. Incidence and mortality rates are stable in this group, the only group that's not seeing declines in incidence and mortality. Mortality rates in Native Alaskans are 3 times higher than those in whites and 4 times higher than Asian and Pacific Islanders. And Native Americans outside Alaska have the second highest incidence rates and tie with black individuals for the second highest mortality rates. But if we look at Native Americans if we look at them separately by region, which we did in this paper that we published last year, led by Tyler Kratzer in my group, you can see the big differences even within the Native American population by region. Rates in Native Americans in the Southern Plains are not far behind those in Alaska and are twice as high as Native Americans in the East and Southwest, who have rates similar to white individuals in those areas. This map on the right is showing where these areas are, but it's also informative because it shows the distribution of PRCDA counties. And these are counties in or adjacent to reservation lands. And so all of the data that I'm showing you on incidence is confined to PRCDA counties in order to reduce racial misclassification, which is extremely high in this population. And if we don't do that, so these data are linked to cancer registry data. If we don't confine to PRCDA counties, the rates are very underestimated. But the bad thing is that only 2/3 of Native Americans live in PRCDA counties, and so we're missing a large swath of this population in terms of informing cancer control. I also wanted to show a unique feature of the data in Native Americans. As I mentioned earlier, overall incidence rates are 30 to 40% higher in men than in women. And this holds true across all the broad racial and ethnic groups that I showed. But Native American women in some areas have the same burden as men. This only happens in 3 other countries in the world. It's very, very unique. And it could be very informative in terms of the etiologic questions about why rates are so high in Native Alaskans. And finally, I wanted to show this slide on early onset colorectal cancer in the Native American community because it's really exacerbating these trends and probably a large part of why the disparities have increased so much, particularly among Alaska Native people. Incidence rates for early onset colorectal cancer in Native Alaskans have doubled since the early 2000s, and mortality rates have increased by 60%. And incidence trends in young adults are actually the best measure of progress against cancer because it reflects contemporary exposures. So in summary, we continue to have overall declines in incidence and mortality rates, but this progress is now completely confined to people 65 and older. And I hope I've convinced you that we no longer just have an early onset problem. We have a rapidly younger cases, patients being diagnosed, and an increasing number of advanced stage diagnoses. So I think there are a lot of opportunities here in these data, and imagine, if you will, what would these data look like if the screening rate in people 45 to 49 went from 20%, where it is now, to 80%? What would that do to these data? And if we could increase the screening rate from 50% in 50 to 54 to 80%, I think it would look very different. The same thing with the wide disparities in racial and ethnic groups, particularly Native American people. If you'll recall, yesterday, Preeti was telling us that the Native American people have low screening rates, but they're actually even lower than we think because a large percentage of them are diagnostic in nature, and the surveys that we report don't distinguish between screening asymptomatic individuals and diagnostic tests. So they're actually lower. So increasing screening rates, the roundtable is more important now than ever in these trends that we're seeing in colorectal cancer. So a lot of opportunity. I'd like to thank cancer registrars across this country who allow this important work and helping to inform cancer control, and my collaborators on this project, including Bob in our audience. And I think we have time for some questions.